on to the next speaker, we have Dr. M. Srinivas Rao Garu, HOD of the Department of Emergency Medicine, Narayana Medical College, Nellore, to give us a lecture on light and shade of new antibiotics. Let's welcome him with a loud applause.
Good morning to all. At the outset, I thank PACE 2016 for giving me an opportunity to talk on light and shades of new antibiotics. All the previous speakers have talked about sepsis, guidelines, timing of antibiotics, but this topic is a little bit of more of theory than practical. And as we all know, this bacteria growing resistance to antibiotics is growing up, leading to increased mortality and morbidity. And we are standing at a threat that we may go back to a pre-antibiotic era where the infections cannot be controlled by our antibiotics that we use today, day-to-day practice. So there is a lot of concern in the research development to discover new antibiotics that have a safety, efficacy, good tolerance, and low resistance profile. And that's the topic today that we are going to talk about, light and shades of new antibiotics. Going back to the history, in 1923, our Alexander Fleming discovered penicillin from penicillium mold, and from that time, various antibiotics like sulfonamides, aminoglycosides, macrolides, tetracyclines, and cephalosporins. In 1985, imipenem came into existence. In 94, cefepime came into existence. In 2000, linezolid came into existence. And various new antibiotics have come into existence. And the last one that is got approved from FDA is ceftazolone tazobactam. And that is the last antibiotic that was recently approved by FDA, and it is in the post-marketing surveillance. And the basics that everyone should know about this peptidoglycan, which is vital for the cell wall structure because it provides rigidity by making a cross lattice between these polymers of glycan polymers, N-acetyl muramic acid and N-acetyl glucosamine. And the importance of this structure is this penicillin binding proteins, enzymes, binds to this and forms a cross-linking. And all these antibiotics, especially penicillins and cephalosporins, act on this penicillin binding proteins, and it catalyzes and results in cell wall disruption and cell lysis, leading to death. Even the vancomycin that is been used for MRSA also acts on the D-ala-ala segments and inhibits the cell wall synthesis. And we talk more of drugs. This bugs tries to always evade the drug by putting some resistance, by altering the cell wall permeability, by increasing the efflux mechanism, all these various resistance mechanisms, and always the war continues between a drug and bug. And in this war, there are some bad bugs called as superbugs. They escape from the antibiotics, and it's popularly called as escape organisms, which includes Enterococcus, Staph aureus, Klebsiella, Pseudomonas aeruginosa, Acinetobacter, and Enterobacteria. And of all these things, again in these superbugs also, the treatment, as we are all fighting every day, is cap organisms, that is Klebsiella, Acinetobacter, and Pseudomonas. And these superbugs may delete the centuries of our medical progress. And that has become the scare, and this scare also created by our own healthcare professionals because of inappropriate and unrestricted antibiotic use, as quoted by the CNN IBN News in 2013, and it has become a superbug scare. So far, till recently, there were, till 2000, there are no definitions that standardize what is antimicrobial resistance. So the group of consensus people come together from European and American Center for Disease Control, and they made definitions to define what is multi-drug resistance, what is extensively drug resistance, and what is pan-drug resistance. Coming to the multi-drug resistance, the isolate that is non-susceptible to at least one agent in 3 or more antibiotic classes are defined as multi-drug resistance. The isolate that is non-susceptible to at least one agent in all but 2 or fewer antibiotic classes comes under extensive drug resistance. And the isolate that is non-susceptible to all agents comes under pan-drug resistance. And today we are fighting with MDR and XDRs, and the day is very near we have to fight with. Already it has started, that's what they say, even colistin has become resistant. So we are fighting, start fighting with the PDRs also, that is pan-drug resistance. And the various mechanisms, as I was telling, the war between bugs and drugs, the mechanisms like altered membrane permeability, inactivation of enzymes, decreased uptake, and increased drug reflex, all these mechanisms make the bacteria to get into multi-drug resistance. Coming to the timeline key of the antibiotics that got resistance, it is not, even with the penicillin, though it was discovered in 1923, by 1940 it has come into the market, and by 1950 the penicillin also has got resistance. And we talk of more resistance bacteria like MRSA, ceftazidime resistant enterobacteria, carbapenem resistant bacteria, VRSA, that is like vancomycin resistant staph aureus, PDR, Acinetobacter, Pseudomonas, and all these things, the multi-drug resistance is growing day by day, and we are combating against those bugs. And those bugs always makes counter moves to these antibiotics and always try to be smart by making some genetic mutations and also acquisition of resistance by getting R plasmids and resulting in various mechanisms of hydrolysis, increasing the porins, efflux, increased efflux, all those things. And it has become a public concern that Center for Disease Control has classified these antimicrobial threats into three threats like urgent, serious, and concerning threats. And we are fighting day to day with this multi-drug resistant Acinetobacter, ESBLs, VRE, multiple drug resistant Pseudomonas, MRSA, and drug resistant Streptococcus pneumonia. All this becomes a threat and made the scientists to started developing new antibiotics. Presently, we are fighting with these MDR pathogens. With the brief I made here, this is what the many intensivists are following in our places. Like for cephalosporins, we are using ceftazidime, cefepime with amikacin. For carbapenems, we have made a double carbapenem regime, high dose extended infusion of carbapenem, and very recently even some intensivists started using phosphomycin with carbapenem to fight these XDRs, tigecycline, polymyxin, and colistin. Even colistin became resistant, as I was told, because of development of MCL-B gene becoming resistant. The triple regime of colistin has been followed, like colistin, tigecycline, and extended infusion of meropenem. That is the dose of 2 grams over 3 to 4 hours every 8 hourly. And with all these fights every day, this IDCA, Infectious Disease Society of America, made a supportive program initiative of 10 into at least 10 in 20, that is to develop at least 10 new antibiotics by 2020 from the existing classes of antimicrobial agents. That's the initiative taken by this IDCA. And before going into this topic of new antibiotics, just I want to brief what are the phases, because if I say just this drug is in phase 1, this drug is in phase 2, that will confuse the students. So before going into that, we should know what are the phase trials, that is the clinical development. The phase 1 is done in normal human volunteers to determine the toxicity and pharmacokinetics of the drug. Phase 2 is done in small number of patients to determine the safety and efficacy of the patient. Phase 3, done in large number of patients at several centers with different genetic makeup. And once this drug gets approved in phase 3, it can be applied for FDA for approval. And after FDA approval, it will be going for a post-marketing surveillance, that is phase 4, to know the rare adverse effects of the drug. So I begin with, this is the list of drugs, the new drugs, cephalosporins, carbapenems, monobactams, from all these classes. the various new drugs have been developed, and some are approved, some are in phase 2, phase 3 trials, some even in the premature stage of phase 1 also. Now I'll just, with a few references from few articles, I'll brief some new antibiotics. This ceftriaxone fosmale is the new antibiotic of cephalosporin, which is called the 5th generation cephalosporin, approved by FDA in 2009. The mode of action is bactericidal, and actually this new drug fills up the gap of activity against the MRSA, VRSA, and heteroresistant vancomycin intermediate staph aureus. And this drug also got resistance from ESBLs and AMC beta-lactamase producing organisms. The light is that this drug can be used in complicated skin, cough, tissue infection, and community-acquired pneumonia. It has a very good synergy of adding the ceftriaxone with amikacin, tazobactam, meropenem, and acetronol. The latest that is approved by FDA is ceftriaxone tazobactam. That's very promising activity against the difficult to treat gram-negative pathogens, that is MDRs, that is E. coli, Klebsiella pneumonia, and Pseudomonas aeruginosa. This is anti-pseudomonal cephalosporin with a beta-lactamase inhibitor, 2:1 ratio, and it is in phase 3 clinical development of trial. Coming to this ceftazidime avibactam, of this the avibactam is very important because it is a non-beta-lactam beta-lactamase inhibitor. It has a good bactericidal activity, inhibits even class A, class C beta-lactamases, and it has high activity against ceftazidime resistant isolates. So it has proven that this drug may be beneficial. Already this avibactam, that is a newer beta-lactamase inhibitor, has come into the market, and it started in as a phase 3 clinical trial. Because there are some gaps in the ceftriaxone, they added avibactam, that is a newer beta-lactamase inhibitor, and it is in phase 3 clinical development trial, and it has a high activity against MRSA and MDR pathogens, but it is having a little bit of resistance with Pseudomonas and Acinetobacter because of the enzymes like oxabeta-lactamase that can produce a resistance to the drug. The carbaminoms have a wide range of wide spectrum of activity. It's basically a bactericidal, and carbaminoms are classified into group 1, group 2, group 3 based on the activity and also based on the chemical compositions, chemical positions of in inner structure. As we all know, the ertapenem nowadays it's not been used because it lacks activity against Pseudomonas. The imipenem is the first carbapenem that is discovered, and the doripenem has a good pseudomonal activity, and also it is been having good synergy with colistin to treat XDRs and PDRs. And the tomopenem has both MRSA and Pseudomonas activity, but it is in phase 2 trials. So the latest carbapenem that are going to come is carbavans. It is in phase 2 trial. It also has beta-lactamase inhibitors with biapenem. The biapenem is the carbapenem, and RPX 7009 is the chemical composition of beta-lactamase inhibitor. It is basically more active than imipenem, but it is not active against our New Delhi metallo beta-lactamase lactamase producing organisms like Pseudomonas and Acinetobacter. The drug dosage is 300 mg twice daily for 1 week, and it is active against UTIs and pyelonephritis, HAP and VAP. And this drug MK765 is a carbapenem imipenem with beta-lactamase inhibitor. This also overcomes the imipenem resistant organisms, but not active against NDMs, beta-lactamases, and OXA48 beta-lactamases. This aminoglycoside group, it is a bactericidal in phase 3 developmental trial. This is the semi-synthetic derived aminoglycoside from sisomycin, and it is active against carbapenem resistant enterobacteria, and it is also active against MRSA. It has a good synergistic action along with some gram-positive antibacterial agents like daptomycin, and also good synergic with cefepime peptides and doripenem and imipenem. Deflufloxacin is a newer fluoroquinolone in phase 2 bactericidal activity. with same mechanism of action as other quinolines, DNA synthesis inhibition, but this is used for fluoroquinolone resistant staph aureus, and this is in phase 2 trial, and it has a efficacy and tolerance profile better than the tetracycline when you're treating with Pseudomonas. Coming to this tedilocid, this is after linezolid. It is active against linezolid resistant strain. It is approved by the FDA 2014. It has a better activity than the linezolid against MRSA, VRSA is vancomycin resistant staph aureus, daptomycin resistant staph aureus, and even against penicillin resistant streptococci. And the advantage over the linezolid is it doesn't cause any hematological abnormalities, and it also doesn't interact with any monoamine oxidase inhibitor drugs, so it can be used with, again with this antidepressant agents also. And the dosage is also 200 mg IV once daily with compared to the linezolid 600 mg BD. Redilocid is another oxylodynine derivative. It is also bacteriostatic and same as todilocid, but it is in phase 2 trial. It also has good activity against linezolid resistant strains. And the cadazolid is an oxylodynine derivative. The importance of this is it has activity against Clostridium difficile associated diarrhea, and it is more better than vancomycin and metrozil by inhibiting toxin A, B of Clostridium difficile, and it also active against strains resistance to linezolid and fluoroquinolones. And coming to this vancomycin derived lipoglycopeptide, telavancin, it is approved by FDA in 2013. It also has a good activity against MRSA, vancomycin resistant enterococci, and coagulase negative staph cons. And the main warrant in this, main caution is that it also has dose adjustment for moderate to severe renal failure cases, impairment cases. Oritavancin is again approved by FDA. It's an analog of vancomycin. It's a bactericidal by means of 3 mechanisms of action: inhibition of transglycolization, inhibition of transpeptidation. All these things will inhibit the cell wall synthesis. And it has a long half-life, 393 hours, and no dose adjustment because it's not metabolized following IV administration, and it is given once in a week. Dalbavancin also is approved by FDA in 2014, bactericidal agent, and it is active against MRSA and MSSA, but not active against VRE, vancomycin resistance enterococci. Minocycline is the old drug that is revisited again and reintroduced by FDA in 2009. The mode of action is bacteriostatic, and it's been used again and reintroduced, revisited again because to fight against, to combat against this multi-drug resistant Acinetobacter. And there should be a caution while using in hepatic and renal impairment cases. The dose is 200 mg stat followed by 100 mg 12th hourly. It is recently been in the market as Milfast also, so it's a revisited drug. Omdocycline is a semisynthetic derivative of minocycline. It is effective than linezolid. It is in phase 3 trial. It is been used again all resistant gram-positive and gram-negative multi-drug resistant strains. Eravicilin is a fluorocycline derivative. It's a bacteriostatic action, active against Klebsiella and Acinetobacter, but not against Pseudomonas. And this phosphomycin has come into the revival to treat this multi-drug resistant agents, and it is a time-dependent bactericidal agents used along with carbapenems. Phosphomycin and carbapenems are used in synergistic action along with some other aminoglycosides also. Initially, it was treated for uncomplicated way, but the high dose of along with synergy with carbapenem, it is used in urinary tract infections and multi-drug resistant nosocomial infections. As I said, colistin 2 become resistant. For that, the research is made to find out what the drug that can be given for colistin resistant bacteria, and still it is in phase 1, CB 182, 184. To treat multi-drug resistant bacteria, Acinetobacter E. coli. Klebsiella pneumonia and Pseudomonas aeruginosa. The clinical indication is not yet known, but it is in the phase of developmental trial. With this, I end my topic, and as our colleague was asking, delegate was asking about hospital-acquired infection. Yes, there are a lot of organisms that exist in the hospital, and the hospital, whether we don't know whether staff is welcoming or hospital staff is welcoming. That is staff, MRSA staff may be also welcoming us. So always we should make a good antibiotic stewardship and infection control programs in the hospitals to combat hospital-acquired infections or nosocomial infections. Thank you all.